welcome to the NOAHE Rounds 5, Session 6. My name is Erin Kerwin, and I'll be facilitating this session. So please join me in welcoming our presenter, Dr. Hadley Stephen-Smith. Dr. Stephen-Smith is a postdoctoral fellow in health policy in the Center for Medical Ethics and Health Policy at Baylor College of Medicine. Dr. Stephen-Smith earned a PhD in health economics from the University of Texas Health Science Center at the Houston School of Public Health. She holds a Master of Public Service in Administration from the Bush School of Government and Public Service at Texas A&M University, where she also studied political science and genetics as an undergraduate. This summer, she will join the faculty of the Department of Population Medicine at Harvard Medical School and the Harvard Pilgrim Healthcare Institute. So huge congratulations for your recent appointment. Dr. Stephen-Smith's research focuses on the health, economic, and policy implications of genetic and genomic testing, primarily for newborn and pediatric patient populations. As a health economist and as a scholar in the ethical, legal, and social implications, or the ELSI, of genomics, she develops approaches to integrate and advance health economic and ELSI research, aiming to inform policies to promote equitable and efficient implementation of genomic medicine to improve population health. So today's topic is measurement and valuation of outcomes in clinical genomics, integrating health economics and ethical, legal, and social implications. Dr. Stephen-Smith will provide an overview of theoretical orientations towards clinical genomics outcomes measurement in health economics and ELSI, illustrated with empirical findings from recent efforts to integrate clinical genomic sequencing in the US. So before we begin, I'll go over a little bit of event housekeeping. Participants will be muted throughout the webinar. To submit any questions during the webinar, please use the Q&A function, and a friendly reminder that the Q&A function is different from the chat function. The Q&A answering your questions will be facilitated during the final 20 minutes of the webinar. And that's it. So thanks again for joining us, and I'll now hand it over to Dr. Stephen-Smith.
Thank you so much, Erin, for that kind introduction. And thank you all for inviting me to present today. I'm delighted to be with you this afternoon. So as Erin mentioned, today I'll be talking about measurement and valuation of outcomes in clinical genomics, integrating health economics and the ethical, legal, and social implications of genetics and genomics, or as I'll abbreviate, ELSI. So the motivation for this talk today really comes from my training in the Texas Medical Center. So again, as Erin mentioned, I earned my PhD in health economics from the University of Texas School of Public Health. And I've completed my postdoctoral training in the Center for Medical Ethics and Health Policy at Baylor College of Medicine, which has a very strong research program in ethical, legal, and social implications of genetics and genomics, or ELSI. And so I've spent a lot of time over the past several years really thinking about how these two fields can be complementary to each other, especially as we think about measuring and valuing outcomes from genomic sequencing and other genomic medicine applications. A lot of the work that I've done over the past several years has been based here at Texas Children's Hospital, which is situated within the Texas Medical Center in Houston, Texas, and also is home to one of the largest pediatric genetics clinics in the US. So just a brief overview of the talk today. I'll start by talking a little bit about kind of the state of translational genomics in the US. And then I'll discuss approaches for bridging the fields of health economics and ELSI, illustrating with a couple of findings from recent and ongoing research efforts. I'll also touch a little bit on what I'm working on as part of a career development award from the National Human Genome Research Institute, part of the NIH, to study the family level utility of pediatric genomic sequencing. So since 2013, the US has invested about $1 billion in translational genomics initiatives. So this includes building clinical cohorts and conducting translational research studies to address some of the barriers to implementation of genomic medicine within routine clinical care. And as a trainee, I have been lucky enough to be involved in several of these national efforts, including the Clinical Sequencing Evidence Generating Research Consortium, which I'll refer to as CSER, as well as the Newborn Sequencing in Genomic Medicine and Public Health, or INSIGHT Consortium. I'll share some findings from both of these consortia as part of this talk today. And in particular, I wanted to highlight some ongoing work that we have as part of the CSER consortium. CSER set a goal of enrolling 60% diverse patients in each of the clinical cohorts. So CSER is composed of 7 clinical sequencing projects that are across the US, and each project has several enrollment sites. And the patients at those sites are diverse in a number of ways, including on race and ethnicity, who have been historically underrepresented in genomics research, as well as areas of the US that are considered to be medically underserved. So just to give an example of some things that we're studying in the CSER consortium that directly relate to integration of genomic medicine into clinical care. I wanted to start with kind of a brief look at what insurance coverage for clinical exome and genome sequencing looks like in the US today. I'll start by explaining the difference between exome and genome sequencing, which I'll refer throughout the rest of the talk just as genomic sequencing collectively, but there is a slight difference between the two. So when we think about exome sequencing, the exome is the approximately 2% of an individual's total DNA that codes for protein products, so is traditionally considered to be the most clinically relevant. Whereas the genome, sequencing the genome involves sequencing nearly all of an individual's DNA, and that genome sequencing can also detect some kinds of structural rearrangements within chromosomes that exome sequencing cannot pick up. So it gives you a little bit more information. And Catherine Phillips and her team at the University of California at San Francisco have led a lot of efforts at characterizing insurance coverage for genomic sequencing in the US. And they have found that approximately 50% of individuals in the US have coverage for exome sequencing, whereas about 12% of people have coverage for both exome and for genome sequencing. And so as part of the CSER consortium, we conducted focus groups with representatives of private payers in the US to ask them kind of what information would they need to move from covering exomes to covering genomes. And what we heard from this group of payer representatives was that they really need additional evidence around the added value that genome sequencing can provide over exome sequencing in terms of ending the diagnostic odyssey for patients, which is kind of the term that we use to searching for a diagnosis for a patient who may be undiagnosed for several years. They also needed kind of additional clinical context specific information about the relative performance of genome sequencing to exome sequencing, and also wanted to know that genome sequencing would not result in a higher number of variants of uncertain significance, or essentially genetic findings that may or may not be relevant for patient health and may or may not call for additional follow-up diagnostic testing. Or clinical interventions. We have also looked within pediatric outpatient clinics in Texas at what insurance coverage looks like for patients. So in pediatric outpatient genetic clinic settings, we do find that insurance coverage remains a barrier to accessing genetic tests that are clinically recommended by pediatric geneticists. We looked at a sample of about 4,500 tests submitted for insurance prior authorization at Texas Children's Hospital and at the Children's Hospital of San Antonio over a span of about 2 years. And we did find that patients who had public insurance were actually more likely to have their prior authorization request approved, or for a prior authorization to not be required by their insurance in order for them to proceed with the genetic testing. And this was true in the case of all types of genetic testing combined, as well as when we looked at just the patients who were recommended to have exome sequencing. However, it is important to note that approval of a prior authorization request does not ultimately mean that a test will be paid for. And also, these levels are not 100%, even for tests that are clinically recommended. So, we do find that this insurance prior authorization and approval is something that remains a barrier for access of genetic tests in clinic. And so since insurance, we know, is a barrier to access in the clinical setting, this is something that we also wanted to explore within the context of genomic medicine research within the CSER Consortium. And Amanda Gutierrez has led this really amazing paper on looking at the construct of access to care and how that relates to access to genomic medicine. And one of the key takeaways from this paper is that access to genomic sequencing research is really an important means of access to genomic medicine today in the US. And all of that access to genomic sequencing research is really kind of predicated on access to healthcare broadly. So we know that we still do have access issues to address within the US healthcare system context. And traditionally, those kind of access and equity issues have not been something that has fallen within the realm of traditional bioethics or clinical ethics, but it is something that has received a tremendous amount of well-deserved attention over the past few years within the Ethical, Legal, and Social Implications, or ELSI, research program of the National Human Genome Research Institute. And ELSI is a community of scholars in bioethics, medical humanities, social science, and legal studies that come together to study essentially how genomics interacts with many aspects of daily life. The ELSI program originated in 1990 with the start of the Human Genome Project, so sequencing the first human genome, so that there would be this community of kind of social scientists and legal scholars and bioethicists who would study the implications of all of the basic science research that was going on. And this program has a dedicated funding stream within the US to continue the study of applications of genomic medicine. So even as ELSI scholars are studying the clinical integration of genetic and genomic testing, you'll notice that there is no explicit mention of economics within our ELSI program in the US. So this is in contrast to the GE3LS or GELS program in Canada, which includes ethical, economic, and environmental implications. So that economic piece is built directly into the program in Canada, whereas that's not the case in the US. But from my perspective with training in both of these fields, I can really see how the integration of health economics and ELSI is key to understanding the full value of genomic medicine applications. So as clinical sequencing has expanded and we're seeing more implementation in clinical settings, there is a large and growing role for health economics and outcomes research. And health economics and ELSI both give us frameworks for how to think about kind of the balance of benefits and harms and trade-offs that we're making on a societal level. And if we want to continue to implement genomic medicine applications in ways that are truly patient-centered and are ethically informed, then I think both of these fields have to work together and be complementary as we think about the full value of genomic medicine. One aspect of genomic sequencing that is particularly interesting to me and that also distinguishes it from other types of diagnostic testing in both an economic and in an ethical sense is that the effects of genomic sequencing extend beyond the individual patient. So by the very nature of the type of testing that we're doing, where we're looking at the genetic makeup of individuals, that has implications for family members as well. And this measurement of kind of family impact of genomic sequencing is crucial due to the nature of the information that is generated in this testing. However, to date, although this is a large and growing area of research, most economic evaluations of genomic sequencing do not fully account for the impact of testing on family members. However, there is a rich tradition of thinking about impacts on family and caregivers within the field of ELSI. And those impacts, those insights from the field of ELSI can be very informative for how we think about measuring and valuing family level outcomes in health economics. And within the US setting, it's also increasingly recognized that family and caregivers are important to consider in value assessment. So the second panel on cost effectiveness in health and medicine states that effects of an intervention on health outcomes on family or caregivers, which are referred to as spillover effects, should be included from both a healthcare sector perspective and from a societal perspective. The Institute for Clinical and Economic Review, which is an HTA organization in the US, says that these family and caregiver impacts fall within the bucket that they term potential other benefits or disadvantages and contextual considerations, and says that interventions that significantly reduce the negative impact of the condition on family members and caregivers suggest that that intervention has higher value. And so that brings us to the question of, okay, if these things are important to measure, how are we actually measuring outcomes of genomic medicine applications currently? This is something that we set out to harmonize as we were developing surveys and designing studies within the CSER Consortium. So a major goal of the CSER Consortium is to produce evidence on utility. And then when this interdisciplinary group of experts sat down to kind of operationalize that and think about how we should be measuring that, we realized that people with training in different fields can think about the construct of utility in very different ways. So this is a very interdisciplinary effort, but kind of the fields of philosophy, medicine, and health economics were well represented as part of this consortium. And so we looked at how people with training in those fields may think about operationalizing this definition of utility and therefore going about measuring it. So folks with training in philosophy may think broadly about the balance of benefits and harms and favor methods like qualitative research methods, interviews or focus groups, or doing surveys with research participants. People with training in the field of medicine may think about the usefulness of the information, so the clinical utility or the personal utility, which I'll expand more on later, and think about measuring changes in medical management or using psychometric outcome scales to measure constructs that would be important to patients from kind of a patient-centered outcomes measurement perspective. People in the field of decision psychology or health economics may think about health-related quality of life or preference satisfaction and use instruments appropriate to measure those. And kind of where we land from this research on how we should be measuring utility in research is that we should be coming up with an operational definition of what we mean by utility and being specific about how we're defining that within the context of a research study. And then use qualitative research methods to gather information on the benefits and harms, and use outcome measures informed by that qualitative research to address multiple informational needs from various stakeholders, so that ultimately we'll conduct evaluations that capture the relevant benefits and harms for meeting those stakeholders' decision-making needs. So one of the key takeaways that we took out of that utility work in CSER, and that others have written about as well, is that there are two primary orientations regarding outcome measurement, as well as how family members should be considered in evaluations of genomic medicine. And those are clinical utility and personal utility. And I'll talk about each of these in turn and give some examples. So the majority of my research has looked at clinical utility for newborn and pediatric patient populations. And we've looked at clinical utility in several different ways and kind of a research progression here, which I'll walk through. So we started with a scoping review of clinical application of genome and exome sequencing as a diagnostic tool for pediatric patients. And we found in that scoping review that the diagnostic yield of the testing, so the number of patients diagnosed out of the total number of patients sequenced, was the most commonly reported outcome measure. And in the studies that were published to date, it was about 32%. So genomic sequencing does have kind of a high diagnostic utility, as you'll sometimes hear it referred to, meaning that it has a high diagnostic yield for a single test. But beyond characterizing the number of patients diagnosed, there was not any consistency really in the way that people would measure kind of outcomes downstream from that. So changes in medical management or changes in health outcomes. And so we set out to kind of characterize what a core outcome set might look like to measure medical management changes. And we did this using a modified Delphi method. So we administered 2 rounds of surveys and then held a teleconference at the end to kind of debrief with pediatric specialists at Texas Children's Hospital. And our goal here was to identify the outcomes that pediatric specialists thought were important to measure in evaluations of genomic sequencing. And we were asking, importantly, not only about which outcomes would be important to measure for patients who got back a diagnostic result, but also for patients whose testing was non-diagnostic. So somewhat unsurprisingly, the clinicians told us that there were a lot of outcomes that were important to them based on Delphi methodology. And we also saw that clinicians tended to think that psychological impacts and that personal or social impacts were important. So it wasn't only the clinical outcomes that they considered important for patients and families, but also these non-clinical, psychological, personal, or social outcomes that they considered important to measure as well, that they thought had some value to patients and families. We have also looked at survival in the context of pediatric genomic sequencing, although this work has several caveats. So we looked at all of the patients who were in an intensive care unit at Texas Children's Hospital over the course of about a 5-year time frame, who had an inpatient consultation from the genetics team for a suspected genetic condition. And for patients who either had exome sequencing or had standard genetic diagnostics, but no exome sequencing. So this could have included things like a chromosomal microarray or single gene or gene panel testing. We looked at these 2 cohorts of patients and we propensity score matched them on important clinical characteristics, including human phenotype ontology terms. So this is a standardized way of characterizing the phenotypic presentation of an individual. So we had two cohorts that had been evaluated for a suspected genetic condition who looks pretty balanced in terms of their clinical characteristics and demographic characteristics. And we looked at diagnostic yield and survival between the two groups. We found no difference in diagnostic yield. It was a little over 25% in both cohorts, and no difference in the proportion of patients who survived to 1 year. But you can see by looking at these survival curves that it's really difficult to kind of interpret what's going on here in terms of survival. So the patients who had exome sequencing, the red line here, tended to do better at 28 days of life, but a larger proportion of them had passed away by 1 year compared to the group who had standard genetic diagnostics. It's also kind of qualitatively interesting here to look at the difference in patients who received a genetic diagnosis, either by exome, the blue line, or by standard genetic diagnostics, the green line, who tended to fare worse in terms of survival to 1 year than patients who didn't get a diagnosis. So I think this really speaks to the severity of the diagnoses that are being made, and also that sometimes arriving at a diagnosis for a child can inform redirection of care. So essentially moving a child to palliative care, which complicates things like looking at survival that health economists might think of as kind of a go-to outcome measure. So we have not yet looked at quality adjusted life years in the newborn and infant setting, although other research teams have definitely looked at that in other clinical contexts. We can also think about kind of the clinical utility perspective of measuring family level outcomes. So you can measure family health in a quality framework, looking at those spillover effects, so health-related quality of life in family members or caregivers. In genetics, importantly, you can also look at effects on morbidity or mortality of family members that may result from cascade screening. So when an individual is sequenced and a specific genetic variant is identified, then we might test family members through the process of cascade screening to see if they also carry that same variant. And so we can characterize in quality terms the benefits that cascade screening may provide. And that's what this research team did in this paper here that I was lucky to be a part of. So looking at cost effectiveness of population-wide genomic screening for hereditary breast and ovarian cancer in the United States. And in this work, it was found that when we included the cascade screening effects for first-degree relatives of women with a BRCA1 or 2 mutation, there were modest improvements in both the health and the economic outcomes of population-based genomic screening. But the American College of Medical Genetics and Genomics takes an even broader view of clinical utility than what I have described so far. So they say in their policy statement from 2015 that they submit that the clinical utility of genetic testing should not only take into account diagnostic yield or effects on medical management or implications for prognosis, but also the health and psychological benefits to patients and their relatives, the economic impact on healthcare systems, and the value that a diagnosis can bring to an individual, the family, and society in general. So from an outcomes measurement and valuation perspective, this is kind of a big task to take on of how do we start to operationalize these things. And a lot has been written about the personal utility. So people have widely recognized that genomic sequencing can provide some value to patients and families that is not directly related to anything to do with the clinical implications of what the results might mean. So there is consensus within both the LC community and within the clinical community that genomic sequencing can affect patients and families, even if it doesn't ultimately change their health outcomes. So there are some real non-clinical benefits and harms that may be involved with genomic sequencing. And this aspect of personal utility is usually explored through traditional LC methods. So using qualitative interviews or conducting surveys with research participants where we may ask them, how useful was this information to you? Do you think it will inform, planning for various things, financial planning, uptake of life insurance, things of that nature. We also can measure through surveys specific psychometric outcomes of benefits and harms for individual constructs that may be relevant to the particular clinical context. And so one example of using psychometric outcome measures comes from the BabySeq project. So BabySeq was the first randomized controlled trial that looked at the impact of newborn genomic sequencing applied as a screening tool for all babies who were enrolled from both the Well Baby Nursery and from the ICU. And we were comparing this to standard newborn screening approaches. And we looked within the BabySeq project at the psychosocial effect of newborn genomic screening on families. So just to give some context here, we ended up sequencing 159 newborns as part of this trial, and 18 of those received information back that was predictive of monogenic disease. So this included childhood onset of disease risk, as well as a handful of highly actionable adult onset disease risks. And we ask 3 key questions in this work about psychosocial effects of newborn genomic sequencing. So how does genomic sequencing affect families? How might those effects differ by the types of genetic results that the families received back about their newborn? And what is the nature of those effects over time? Are they fairly transient, or is this something that impacts families over a longer period of time? So this is how we chose to measure each of these constructs within this trial. We surveyed parents at 4 time points: at baseline, when they enrolled in the trial, immediately post-disclosure, so right after receiving their results, and then 3 months post-disclosure and 10 months post-disclosure. And we were primarily interested in those 3 domains of the parent-child relationship, the parents' relationship with each other, and parents' own psychological distress. And for these outcomes that we measured at 3 or more time points, we analyzed them using a generalized estimating equations approach to see if there were differences in the response patterns over time between the randomization arm. And then we looked within the sequencing arm to see if there were any differences in response patterns over time for parents who got back monogenic disease risk information for their child, remembering that this is a small sample size here, versus those who did not. So I'll kind of orient you to how the results will be presented over the next couple of slides. So we're looking at randomization arm results on the left, and within the sequencing arm, the monogenic disease risk results on the right. Sequencing arm is shown in red, whereas the MDR group is shown in red here. And importantly, we found no differences over time in response patterns for mother to infant bonding that we were concerned with looking in the parent-child bonding domain. Similarly, we looked at parents' perceptions of the child's vulnerability using the vulnerable baby scale, and we found no difference ultimately in the response patterns over time, although we did see kind of a small blip at immediately post-disclosure, where the control group scores dropped a little bit lower more quickly. We also looked at the parents' relationship conflict. So this was measuring conflict between the baby's parents using a novel measure. Found no differences between randomization arms over time here. Similarly, we looked at relationship satisfaction using the Kansas Marital Satisfaction Scale. And while we did see a difference in response patterns over time for Kansas on the Kansas Marital Satisfaction Scale, ultimately by the 10-month follow-up period, the magnitude of those differences had decreased. We also looked at anxiety measured via the Edinburgh Postnatal Depression Scale, and we saw no differences in response patterns here. And similarly for depression, using the full Edinburgh Postnatal Depression Scale, we saw no differences in response patterns. So ultimately, we can conclude from this work that there was no evidence of sustained psychosocial harms of newborn genomic sequencing on families enrolled in the BabySeq project, looking at the 3 domains that we investigated. So parent-child relationship, parents' relationship with each other, and parents' psychological distress. Because the BabySeq trial was one of the first studies to look at implementing genomic sequencing as a screening tool in this way, we were being a little bit cautious in the fact that we were primarily looking to detect any harms that may be present. But as we've progressed forward and as genomic sequencing is now more common, especially in the newborn period, as we move into this next iteration of the BabySeq project, which we're calling BabySeq 2, we're also kind of interested in looking at what benefits may be present, or what positive impacts may families experience from having this information. And as we wanted to investigate those benefits, both in BabySeq 2 and in CSER, we realized that there was not an existing tool to really capture in a rigorous way this construct of personal utility to families. Although this is an active area of research and many people are studying this topic, and really wonderful progress is being made. We did choose to focus on this within the CSER Consortium, given the emphasis on measurement of utility and measuring utility from different stakeholders' perspectives. So within the CSER Consortium, we are funded on a supplement project to develop and validate a new patient-centered outcome measure of patients' and parents' perceived utility of genomic sequencing. So ultimately, we'll end up with 2 kind of sister instruments, one for administration to parents and one for administration to adult patients. And so we started out this instrument development work with doing some formative qualitative research with representative enrollees from each of the 7 CSER projects. So you can see the difference in clinical context represented here, as well as the types of information that parents were getting back, or adult patients were getting back as part of each of the studies. We talked to 60 people in total as part of this formative qualitative work. And our interview participants were diverse in terms of not only those clinical characteristics that I just showed, but also their individual demographic characteristics, and obviously where they were located within the country, and which clinical projects they were enrolled in. And as a result of integrating the findings from that qualitative work with findings from the robust literature that exists on personal utility already in the literature, we developed this 5-domain model that will guide our subsequent instrument development. So we ended up with this 5-domain conceptual model that includes domains of cognitive, behavioral, emotional, and clinical utility. We have written items for each of these domains and are currently in the process of pilot testing that item pool and moving forward with instrument development. So we are hopeful that over the course of the next couple of years, we'll have a rigorously developed and validated instrument that can be useful for other researchers to implement in their projects as well. But ultimately, we get to this point where neither traditional LC measures nor traditional health economic outcome measures alone are able to sufficiently account for family impacts in genomic medicine. And this is something that I'm thinking about in particular as part of my career development award. It's also been recognized in the health economics and outcomes literature that there are these what are called novel elements of value beyond traditional quality approaches that may be valuable to include in health technology assessments and value assessments. So these novel elements of value are shown in teal here. And I've pointed out a few things that I think are particularly relevant in the genomic sequencing space, particularly this real option value, the value of hope, and the reduction in uncertainty, which some people will call the value of knowing information. And there is a movement toward, valuation of these novel elements of value, sometimes in monetary terms, using different valuation approaches. So when we think about valuation of genomic sequencing, there are potentially many ways to do this. What I will be focusing on is using a discrete choice experiment, which is a form of stated preference survey that can elicit patients' preferences for individual aspects of a genetic testing intervention. I would point out that this figure comes from a paper led by Dean Regehr at BC Cancer, and Deborah Marshall is also on this paper. And there are a lot of people who are really pushing the field forward in applying these stated preference surveys and different preference elicitation methods within the genomic sequencing space. And so discrete choice experiments, or DCEs, are increasingly popular in health in general, but also in the field of genomics around the world. And so this figure comes from a recently published review of use of discrete choice experiments and conjoint analysis on genetic testing. So you can see the types of attributes that people are including in these DCE studies that look at genetic testing applications. So discrete choice experiments, as I'm sure many or most of you are aware, are a tool used to quantify patient preferences. So theoretically, they're based in Lancaster's economic theory of value, which says that goods and services have characteristics or attributes that are what consumers care about and want. And also random utility theory, which says that respondents will choose the choice set that provides them the higher utility. And in practice, what this looks like is administering a survey to research participants that ask them to choose the profile of attributes that they would prefer among an experimentally manipulated kind of set of choices. And ultimately, what this does is allows estimation of the value of knowing a diagnosis in a way that can be incorporated into comparative analyses in the specific context of genomic sequencing. So importantly, in designing a discrete choice experiment, best practices recommend that formative qualitative research should be done. So obviously this is kind of where the LC meets the health economics, in that formative qualitative research is based in the LC tradition and can help inform the design of the discrete choice experiment in identifying the features of genomic sequencing that would be important to include, as well as describing the attributes and their levels as we move forward into operationalizing that discrete choice experiment. So I'll just briefly mention that this is ongoing work as part of my project looking at family level utility of pediatric genomic sequencing, where we're asking families from Texas Children's Hospital whose children are being seen in the pediatric genetics clinic what matters when undergoing a genetic evaluation. And so we have conducted semi-structured interviews with parents and caregivers of these patients that have aimed to explore the scope of factors that are relevant to their decision of whether to undergo genomic sequencing for their child, focusing specifically on what was important to them from a family perspective. And we are currently wrapping up analysis of these data and writing them up. And we have kind of bucketed our features that we found important from what the families told us as health, process, and experience candidate attributes that will be further refined, which I would be happy to come back and speak to you all again about once that DCE has been administered. So ultimately, I just want to wrap up here by saying thank you to my project team on my K, my wonderful team of mentors and collaborators, and also express some hope that moving forward, fields of health economics and ELSI can be mutually informative to each other as we think about capturing value of genomic sequencing from a broad analytical perspective. I will also give one brief plug before moving on to questions to say that I am a co-convener for international research and collaboration of the IHEA Economics of Genomics and Precision Medicine Special Interest Group. So you can follow us on Twitter. You can share your papers with us. If you're working in this space, we'd love to interact with you. So please reach out either on the Economics Twitter account or on my personal Twitter account. And we'd love to get you involved in the SIG or to share your work and amplify it from our platform. So I'll end there, and I think we have a few minutes left for questions.
Great. Thank you so much, Dr. Stephen-Smith, for that excellent presentation. That was great. So now we'll invite attendees to use the Q&A function on the Zoom software menu. We already have several questions in there, so we'll start with those. And anyone with further questions after today's webinar is encouraged to email noah@ihe.ca. So I'll get started on the questions and I'll just read them out and then give you a chance to respond. So the first question is from Dr. Chris McCabe. What was the coverage status of the participants in the BabySeq trial? My thought is that information without the ability to act on it because of financial barriers to care might have a different psychological impact profile. And has this been explored?
Yeah, so this is a super important question. So our families who were enrolled in the original BabySeq trial were all enrolled from the Boston, Massachusetts area at 3 hospitals in Boston. And we did not have as much diversity in race or ethnicity or income level or education level as would be representative of the US population as a whole, right? And so as I mentioned, we are now funded for a second iteration of that trial, which we're calling BabySeq 2. And we have made it an explicit goal to diversify the research participants in a number of ways. And one of the ways we're going about that is enrolling from several different sites across the country. And really, engaging thoughtfully with stakeholder advisory boards, community advisory boards, who will help us make sure that as we're designing the second iteration of the trial, that we're doing so in a way that is compatible with enrolling a more diverse and a more representative group of participants. So we will look at some of these same psychological kind of impacts as part of the second iteration of BabySeq as well, with a careful eye towards whether we see differences based on resource level of the patients and families that may indicate something about their ability to receive follow-up care.
Okay, great, thank you. So the next question is, spillover effects from genome sequencing are more readily identifiable than for other conditions. One implication might be that if we include spillover effects in HTA, people with genetic conditions will have an unequal call on healthcare resources. Has anyone looked to see if there is an ethical basis for such preferential status?
So this is an interesting question. So I think definitely the cascade screening effects are going to be different from genetic testing because the quality of the information that you get back is different for genetic testing than for other types of clinical diagnostic tests. In terms of spillover effects from genetic testing, I don't think that this has been really carefully described yet. I would say in the clinical context that I tend to think about, so we're thinking about children who will have active caregivers in their life. Oftentimes these genetic conditions that present in childhood can require a lot of caregiving time and effort from a caregiver. And so there may be spillover effects that are related to the caretaking responsibility of that caregiver. But it's unclear to me on its face whether spillover effects would necessarily be larger for genetic conditions than for other types of conditions. I think that's an empirical question that hasn't really been carefully answered yet. But if anyone has additional data on that, I would be happy to learn more about it.
Okay, great. Well, you've left your contact information, so we know where to follow up if anyone has that information. Okay, so next question is from Dr. Ellen Rafferty. Have these novel elements of value been employed in the measurement of outcomes for other diagnostic tests, or has this been focused on genomic sequencing? And if yes, why?
Right. So the novel elements of value, or what you'll sometimes hear referred to as the value flower, is being looked at in other contexts as well. So, for example, the real option value. I have a friend who explores these questions in cancer. So if you receive treatment for a cancer that extends your life long enough that you're able to benefit from a new treatment that has come online that you are still alive to be eligible for, but you might not otherwise have been. So that's an example of kind of real option value being employed there. I also know Dr. Shelby Reed at Duke University has looked at measuring the value of hope within cancer patient populations as well, using discrete choice experiments. So these novel elements of value are kind of are definitely broader and are something that we're starting to think about how we could measure within the context of genomic sequencing.
Okay, great, thank you. So the next question is from Dr. Emma Wang. She says, thank you, Dr. Smith, for this great sharing. I'm currently working on a project of health economics of reproductive carrier screening. In the aspect of utility measure, do you think it will be different with the directly diagnostic genetic testings, such as reproductive options?
So if I'm understanding the question correctly, do you think it will be different with directly diagnostic genetic testing, such as reproductive options? So maybe people might make different reproductive decisions based on the type of genetic diagnostics the information that they get back from genetic diagnostics. That is, I will say that's an area of active research right now. We definitely do consider that as part of the personal utility aspect. So typically kind of framed from the perspective of informed family planning. And it is something that, parents can potentially receive kind of personal utility from, right? Or think has value to them for their own kind of life planning purposes.
Okay, thank you. So we have one more from Dr. Chris McCabe. Given the evidence in pediatric preferences that children and parents value different things and the same things differently, is there a risk that family level utility will be an average of two things that shouldn't be combined?
I think that's a really important point, and also something that we need additional empirical investigation on. Definitely recognize that anytime we're asking parents to disentangle effects on themselves versus effects for their children, and then also whether the children might kind of respond in the same way as their parents' proxy. That is important. I think that this is a new area of research within this particular context, and something that I'm looking forward to continuing to investigate in questions exactly like that one over the next several years, as we really delve into what is this construct of family level utility and how do we best measure it in a way that hopefully avoids things being combined that should not be combined.
Yeah, I'm sure that's going to be super interesting to learn more about. Okay, one more question from Chris. Given unequal access to coverage, has anyone looked at the distribution of harms and benefits from cascade testing following on genome sequencing?
So I will say generally in the US setting, uptake of cascade testing outside of kind of a research context is low. Part of that is because we rely on what's called a proband mediated system, typically in the US, where we just rely on patients receiving their results and then telling their family members and encouraging their family members to follow up with whatever type of testing might be indicated. We know that these general barriers in access to care exist, and I think there is more work to be done in thinking about what barriers exist for receipt of cascade testing, and what that might mean for how cascade testing should be covered, or the supports that we might need to put in place to facilitate that cascade testing, be it communication supports or financial supports, or thinking more carefully about who has the insurance coverage kind of required to receive that indicated care.
Great, thank you. Maybe you can go back a couple slides. We have a question about what was that HealthyCon Twitter handle that you had shared earlier.
Yes, let me see. Okay.
All right. So one more question. Why do you see reduction in uncertainty as a novel value? There is extensive literature on uncertainty in HTA decision-making.
Yeah, so I think this is, I'll start by saying that, the value flower is not something that I personally came up with, so I can't take credit for that at all. But, when we think about reducing uncertainty, that can obviously take on a lot of different characteristics. And one way that reduction in uncertainty has been described in the context of genetics has been value of knowing information, right? So that conceptualization gets at the fact that simply knowing this genetic information, it's kind of analogous to the personal utility construct, right? So knowing this information gives you value in some way, and allows you to use it for life planning purposes, or to reduce anxiety about what the future may hold, that sort of thing. So I think it is more about how that information may be beneficial to the individual. Although definitely people have written papers about that specific kind of petal of the value flower, and have talked about it in different ways. So I think that's an area that that we should maybe think about defining a little bit more specifically, or at least defining in the research that we do in terms of how we're thinking about that construct.
Yeah, thanks. I would have to agree that thinking about uncertainty from the patient perspective rather than as a social decision maker perspective is going to be really interesting to watch that research develop. Okay, so we are at time. So I'll just say thank you once again, Dr. Stephen Smith, for your seminar. And thank you to everyone online for taking the time to attend today's rounds. And you can subscribe to NOAHE by visiting noah.ca for news on upcoming events. Thanks again. Bye.